This is Mark Pew again, and I'm glad to be joined by friend and clinical mentor, Dr. Mel Pohl. I met Mel first time back in 2011, I think, when he was the medical director for Las Vegas Recovery Center. And now he's elevated himself to a job that doesn't take as much of his time, the chief medical officer. So Mel, tell everybody here a little bit about you and your background.
Sure. Good to be here, Mark. I am a family physician and an addiction specialist, and have worked at Las Vegas Recovery Center since its inception about 16 years ago. And about 10 years ago, opioids were really the prevalent, most common drug that people came in to be treated for. And about half the people that were on opioids would get through with their detox, which was 5 to 10 days, and they'd say, "What are you going to do about my pain? Because I'm on opioids because of pain." And I'd say, "I don't know. That's not what you're here to be treated for. You're here to be treated for your addiction, and I've taken care of that." And there was no good answer for them. So I got real interested and so did the center in creating a program that, after taking people off their opioids, could really meet the needs related to their chronic pain. And that's become my life's work.
Absolutely, and you've been very open about your pain, your chronic pain. In fact, written a book or two about that, and that certainly has probably informed kind of your approach and maybe even your empathy for patients who, got rid of that addiction, but then were left with that physical pain. Explain how that, the fact that you're kind of in their shoes to some degree, how that helps or hurts your perspective and your outreach to them.
Well, I think that it certainly is helpful. I think that most patients with chronic pain are horribly misunderstood by the physician who's prescribing medication, misunderstood by the surgeon who supposedly fixed their condition and they're not any better, misunderstood by coworkers and friends, and really misunderstood sort of by themselves. They really don't feel like they have a legitimate complaint, but they know they're struggling with this awfulness, this state of being. And, I had some of all of that. So it gave me an opportunity to really see what the truth was, which was the pain is real, and, stretching and epidurals and surgical intervention and more epidurals and medication is not going to really do the job with chronic pain most of the time. Certainly it didn't for me. And I began exploring alternatives, and along the way I met some very enlightened physical therapists, and I met an acupuncturist who did revolutionary work, and began my own exercise protocol and would get regular massages and all sorts of components of what I think of as pain recovery. And I got real interested in meditation, mindfulness practice, just to name a few of the skills that I use to deal with my pain, and which it turns out translates into the ability to really help other patients with similar problems and that similar sense of misunderstanding. The disadvantage, perhaps, is that it's hard work, sitting face to face with patients day in and day out who are struggling with pain. It triggers, the brain of the person who is sitting with them. So it's an area with potentially high burnout. Not that I burned out, but the shift in my clinical work has happened as a result of doing this for a very long time and wanting to do something different.
Gotcha. And I've read about burnout actually a lot about physicians. And one of the things we're dealing with in workers' compensation, I think in other parts of healthcare as well, is that patients have been dropped non-strategically by physicians who don't want to prescribe opioids because the DEA is breathing down their neck, or the CDC guidelines have been misunderstood or whatever. And so these patients, injured workers, are trying to find treating physicians to assume their care. And it's tough work to consciously decide to take on someone who is addicted, who's on polypharmacy regimens, who doesn't have high resilience, who had maybe adverse childhood experiences when they're growing up, and all those different kind of things. So I get that, I read that. As you see someone if running a functional restoration program, those are the people oftentimes that you'll see, obviously, so you're assuming that responsibility. What helps you and your staff and your colleagues to kind of take a step back and not go, oh my gosh, this is a train wreck and what am I going to do? But, how am I going to peel the layers of the onion back, I guess, and get to the root cause of what's going on?
Well, I can tell you that I get a lot of referrals from workers' compensation case managers and colleague physicians, pain doctors and surgeons and interventionists who, joined a family to help prevent the ongoing process of addiction. And the typical voice on the other end of the phone says, really sorry about this one, Mel.
They're apologizing in advance, huh?
They're really tough cases. And my response is usually, this is what we do. And what enables us to do it effectively, I believe, is that we have a clinical team made up of physicians and nurse practitioners and physician's assistant and nurses and clinical associates and counselors and psychologists and acupuncturists and massage therapists, physical therapists, all of whom are working with different aspects of this very complex problem. I mean, think about giving somebody a pill 4 times a day for this multidimensional problem that is chronic pain. It's an unrealistic solution. So what we really need is a multidisciplinary approach. And in my experience, it works better when they get to spend some time in a facility that delivers that kind of care.
Yeah, y'all are one of the very first functional restoration programs I visited personally, and I think I've been there twice actually. And I believe the second time, one of the PAs I was talking to talked about vitamin D deficiency, and some experience that y'all had some patients coming in that were consistently deficient in vitamin D. And at some point, you just stopped testing that and just flooded them with vitamin D on day one. And I'm assuming there are other experiences like that that you've kind of lived through. Can you kind of explain how a program evolves over time based on not just science and clinical studies, but actual experience with patients?
We hear so much about evidence-based treatment. And the truth of the matter is that evidence and clinical studies that are well controlled don't really reflect what's happening in a patient. We grab this population and we compare them to a very similar population. We exclude, typically, clinical studies for pain treatment exclude people with addiction. So, we pretty much put our program together related to what we felt and learned from the literature seemed to be effective, like, as I mentioned, massage and acupuncture and yoga and qigong. I mean, there's small databases for all those kinds of interventions. Mindfulness has a ream of interventions that suggest that it's extraordinarily beneficial for people with chronic pain conditions and anxiety and depression. And then we just sort of molded the program around the individual needs of the patient. Different patients show up. We have people with fibromyalgia, we have people with spinal structural disease, we have people with chronic headaches, we have people with interstitial cystitis, we have somebody who has an Ehlers-Danlos syndrome, a hypermobile joint syndrome with terrible arthritic pain. So you can't create a program that meets everybody's needs. You have to create the program around the needs of that individual patient. And that's what our team is really expert at doing. We use a lot of cognitive behavioral therapy, CBT, and acceptance commitment therapy and dialectical behavioral therapy, because people's thoughts are distorted around their experience of pain. And it's absolutely crucial that they work with those thoughts. And, I've done that in my own work and certainly with patients. And there is good data that suggests that it's very effective for people with chronic pain.
It's funny that you bring up, because I've got my favorite quote of yours, and I've used it in several presentations just to talk in terms of how important the brain is to pain. It says, when I ask patients about their pain, 8 out of 10 words they use to describe their experience are emotional. The three most frequently used terms are anxiety, fear, and anger, but there's also depression, helplessness, loss of purpose, frustration, guilt, and shame. I assume you remember saying that at some point or writing it. What does that have to do with, and I know you've talked a lot about the psychosocial, spiritual components of this, kind of distill those, how it works in the brain and how it transitions into pain. How do you help someone who's dealing with that sense of helplessness and depression, et cetera?
So, Mark, we have a good physiological basis to understand that the experience of pain is mediated by neurotransmitters within the nerve cells in the part of the brain that experiences emotion, the limbic system. And we've got functional MRI studies that actually prove this. And we're talking now about pain that's lasting more than 6 months. And the way I think about it and the way I've learned about it is it's almost like the signal, my pain comes from my bulging disc in the back, but the signal travels up my spine, and it's really not even pain until it hits this area in the midbrain, the limbic. Well, the limbic system is responsible for all of the emotions. It's the survival center of the brain. So pain is part of survival. You have to know you're injured, so you protect that area. But also being on alert is part of that. Being motivated for food and sexual encounters and nourishment and well-being are all part of this middle part of the brain where emotions happen. And the thoughts that go into that part of the brain comes from the frontal part of the brain, the prefrontal cortex, where we formulate these concepts like my back is killing me, or my feet are on fire, or I can't go on, I can't get out of bed, I can't, all those thoughts that grow out of that emotional distress, and the physical sensations sabotage anybody's ability to get well. We found recently, we're doing some studies on a phenomenon that you're familiar with called self-efficacy. And it turns out that people who perceive that they are victims and you have to fix me and do something for me, whether it's medication or treatment or procedures or, the 6th surgery and somebody's had 5 surgeries, do much less well than people who grow. And in our program, we actually can measure a change in the sense of self-efficacy. The more self-efficacious the patient becomes, the more effectively they can manage their problem, and their pain goes down and their function improves. And those are the really functional improvement is what we're after. Pain score decrease is a secondary but significant goal for most patients.
So ultimately, your goal when someone exits your program is that they're able to self-manage their pain, whatever coping mechanisms they have figured out along with your guidance. It's really on them to kind of live their life from that point forward.
Well, they're not going to take the acupuncturist home with them. They're not going to take the physical therapist home with them. They are taking themselves home. So clearly, going to physical therapy and learning how to stretch yourself and do strengthening exercises and do mobilization skill sets for a sore shoulder, for example, all those things can be done by the patient at home. Even an acupressure phenomenon, we can teach people acupoints and they can actually use their hands to stimulate those acupoints. Not quite the same as a needle, but it still is effective. Mindfulness meditation, people say, oh, pain treatment is so expensive. Mindfulness meditation is present and free for the taking. Now, getting people to subscribe and to practice and to follow through is the biggest challenge because, we are humans and humans tend to, do the least restrictive activity, if you will. But part of our treatment is really to motivate somebody and then hopefully have them sustained in the long run. And that's the biggest challenge is after they leave our very supportive, very structured environment, getting them to continue to do that at home is really probably as big a challenge as any.
Mm-hmm. Hmm. Well, I always learn something from you, whether it's over a meal or co-presenting on a panel or just hanging out on a webcam like this. Is there anything as we close up? Is there any final nuggets that you would like to impart upon those that are watching and listening?
Yeah, the main nugget is around opioids. Opioids appear to be a good solution for chronic pain because when you hand the patient a script and they take that medicine, they get temporary relief. They are not a good solution for chronic pain. And the reason the CDC passed the guidelines and the reason the culture has begun and needs to shift away from using a medication to treat this very complex multiphasic problem with one pill 4 times a day is that it's not the right solution. For patients who are already on opioids, they need help getting off. They need skilled clinicians, professionals that can facilitate decreasing the dose gradually if necessary, because between doses they're in withdrawal. And not everybody's going to get to the level that the CDC recommends. And their risk of overdose is higher because they're on a higher dose of opioid. But really, I'm looking for a paradigm shift, to use your words, in the way the field, workers' comp docs and pain docs and internists and surgeons look at this complex problem, this multi-disciplinary problem that involves so many circuits in the brain, and stop thinking there's a simple solution, because there's not.
Very, very well said. There's no silver bullet, and we want that simple solution, especially in this instant gratification kind of society that we live in. What you're saying is not instant gratification whatsoever.
No, it's hard work. It's really hard work. People that come to our program are very courageous.
Yep. Well, and you are too, in helping people through that. And I appreciate all that you've done to help the people that have been through your program. And hopefully people have gotten, I'm sure they have gotten a lot of insights from you during this time. So Mel, I really appreciate your time on this, and look forward to the next time that we can sit down and have a meal together.
Look forward to it as well, Mark. Thanks for the time.
Great, thanks.